I am now going to introduce our next speaker. I think Claire has joined us. And I'm delighted to introduce Clare Rayner. She's a consultant physician in occupational health medicine, and she is a co-lead for the patient and public involvement in the locomotion study, which we discussed earlier.
Thank you. Thank you very much, Leslie. Thank you for inviting me to be here as well. Yes, and I'm going to give you a patient perspective. I'm also a person who has autonomic dysfunction. And my story with long COVID has been one that I didn't expect, but I've been very much at the forefront of raising awareness about autonomic dysfunction from early on in the pandemic. So I thought I'd just tell you a little bit first about what I saw at the beginning and how I recognized that there were autonomic problems going on. So I was a patient with autonomic dysfunction for a few years before the pandemic. And as you probably know, autonomic dysfunction can be associated with other conditions. So I've got one of the underlying conditions that can be associated. So I was under specialists for I have very low blood pressure aspect of things. So I was just quite aware of it, and I'd learned a lot about autonomic dysfunction. And the professor that I was under, I was in touch with him at the beginning of the pandemic, and I said, look, I think we're seeing a lot of problems caused by COVID. And he said something very wise, I thought. He said to me, look, whenever there's a major world crisis, historically, there have been huge leaps in our understanding of the autonomic nervous system. And he gave several examples, but the pandemic is probably one of those. So I'm very grateful to everybody that's here today because, you are aware of, you're starting to become really aware of it, if not experienced already. And I do think the number of people affected now will lead to quite a lot of learning amongst the healthcare services, because it really is something that affects so many patients, and we can all do with knowing more about. So I think it's really worth bearing in mind that as regards COVID and long COVID, the virus that causes it is a vascular virus. It attacks blood vessels. So it's no surprise to me that we end up with things like PoTS or orthostatic hypotension. It really makes sense. And I'm sure you've already heard that viruses and other infections are probably the commonest trigger for autonomic dysfunction worldwide. So I think we could expect it, and we're certainly seeing a lot of problems. So when it was early 2020 and I had COVID at that time, there were patients getting together in groups, but from that time, there's been a lot of doctors affected by COVID and long COVID. So a group of us were very active in the early days trying to work out what was happening to us. And because a lot of people got infected at exactly the same time, within a week or two, it was very clear that there were certain patterns of symptoms that we were all getting. And one of the things that I saw was that people were complaining of these very fast heart rates that were quite disabling to them. And the key thing really in the history was that it was on certain activities. Sure, there were some people that seemed to have a, permanently raised heart rate, but a lot of people were describing the classic change in symptoms and disability on changing their activity. And obviously going from lying or sitting to standing was one of the big ones. So I think, the real clues in the history are somebody that says, my heart rate shoots up when I stand up. And in long COVID, they describe the smallest activities can set this off. And I can't explain to you why, but what we hear often is brushing my teeth or taking a shower. So it can be really small daily activities like brushing your teeth. So I think that the key is in what you hear. It only comes on when I do such and such. There's another strange but common symptom that apparently has a medical name, and people here may know more than me, but a lot of people describe that their heart rate goes up and their breathing rates when they were bending over to do certain activities. And it actually has the medical name of bendopnea, which seems really strange to me. So that's a common pattern in long COVID. But they also describe anything where they're using their hands up. So I guess brushing teeth can come into that. And I think it's this whole thing sometimes of your circulation being in your feet. So what then happened was we linked up with other hospitals and so on, and I will mention Mount Sinai Autonomic Department in New York, which I linked up with early on, but I'll say a bit more at the end when I talk about perhaps the type of exertion that may or may not help. So the next main point that I want to make, by the way, I do have a slide, but it's only one slide really, and I just kind of think it's perhaps easier just to talk things through, is what matters is the effect of the autonomic dysfunction on a person's function. As with anything else, it's the effect of the condition on their function that really, really matters. Now, I've been an occupational physician. What we deal with, it's a lot of different things. One of the things is we look out for things that make people ill at work, and that can involve dealing with a lot of chemical agents and biological agents. One of the things that we deal with is people who are exposed to nerve agents, pesticides in their work. And what you see with COVID is something that gets to the small nerves and the blood vessels and so on. So it's almost like what you see when you get somebody with a nerve agent poisoning. Just bear with me, I'm not going nuts. These nerve agents actually attack the autonomic nervous system. So we have a biological, a virus basically, which does similar. What's the treatment for that? It's to take away the cause, number one, and then to support the autonomic nervous system. And you have to support all aspects of the autonomic nervous system to get it back into the state of better functioning. So with COVID, that may mean making sure that you have a proper initial rest period. You know, when you get ill, first of all, don't really push it, rest. Give the body a chance to clear the virus. But then in terms of how you manage it, it's supporting all the different elements of it that are disrupted and trying to get back into that more settled parasympathetic state. So how do we see this affects people with long COVID? It's really, as I said, daily activities, but often impacts on work. People really struggle to do work because it requires often being upright, even sitting upright. So the important thing is to recognize the autonomic dysfunction. And then you can give all the advice and treatment such as you've heard earlier this morning. My colleague, Professor Sivan, earlier today, when talking about the work in locomotion, will have presented his studies where he showed that in the clinics with long COVID, a large proportion of them are symptomatic. The symptoms are suggestive of autonomic dysfunction, but that you need to screen everyone with long COVID. You need to screen their blood pressure and heart rate in everyone, because it's so common to have autonomic dysfunction like PoTS and orthostatic hypertension that you just have to screen for it. And why is that important? If you can identify it, there really are all these things that you can do to help so much. And what I've seen is if you get the right trigger management, the right fluid management, in many cases, medication for a certain time, their daily function improves so significantly that they can go back to work. So I really think it's important to screen all your long COVID patients for this and treat accordingly, whether that's non-drug or drug methods. and one of the things that's also come out of the locomotion project is they talk about treatable traits. So within the umbrella of long COVID, to screen for certain conditions and then treat and manage them. So in terms of the fatigue, this can improve when you treat the autonomic dysfunction. Treating inflammation and inflammatory reactions can also help. So I think that's the importance of identifying it and then managing it. What we've seen in the long COVID community is that whilst many people will need some medication for their PoTS or other autonomic dysfunction, it doesn't necessarily have to mean forever. It depends on the individual, but with long COVID, you quite often see it's having that period of support in for a few months and then gradually weaning off it again if they're improving significantly is perfectly possible. I want to just mention about the adapted autonomic protocol. Leslie, did Manoj mention that? Yeah. Oh, sorry, you're on mute.
Sorry, yes, we did just cover it briefly earlier.
Yeah,
and we showed a picture, an image of one that was completed. Yeah.
Oh, great. That's lovely. So my involvement in this actually was I helped to develop it for COVID, for long COVID, because as I say, I was under an autonomic unit and the professor that used to look after my care had developed this in his clinical practice at the National Neurological Hospital. So it was something he'd used to monitor people's treatment. And at the start of the pandemic, he said, look, we're in lockdown. A lot of clinics are having to go to virtual. And a lot of people are developing PoTS and so on through having had COVID. We can't possibly see everybody. There needs to be a simple way of helping to monitor people at home. So we adapted, we slightly simplified and adapted the protocol for something that people could use at home if necessary. What it's useful for, I think, is to identify particular triggers. So it's worth looking at blood pressure and heart rate after food, after exertion, first thing in the morning, and it can just really help. Sometimes, particularly with the food-related things, people can have a wider autonomic dysfunction that's useful to pick up. So I think it's just a helpful extra that people can use at home, and it allows people to adapt their treatment sometimes. What I want to briefly mention now is long COVID and work and autonomic dysfunction. I do have a couple of slides I'd like to share here. I emailed them through just now. Do you want me to try and share my screen, or Denise, are you able to, did you get it?
I did. I'd need to get them up. Are you able to share yours?
Yeah, I can try. Should be able to. Yes, I can. Okay. So can people see that?
Yes.
Great. Okay. So early on in the pandemic, as I say, I was working with several other doctors. I did link up with Mount Sinai in New York because I saw that they were doing very similar work, and they had a big autonomic unit. So there was a Department of Innovation Rehabilitation where they were the first long COVID clinic in the world. And the UK doctor said, right, we'll write stuff for you. But the New York people said, we'll give you all our information. We just haven't got time to write it. But so they said, we'll give you all the clinical information we can, and if you could help disseminate it. So one of the things that they said from this first long COVID clinic in the world was that the autonomic dysfunction was really common. They were seeing it in 80% of their patients, but that they were finding it very difficult to find a level of exertion that was suitable for people because the nature of the virus itself seemed to so debilitate people. So very much to start with the really basic supine levels of exercise, and really gently build up according to each individual response. So then over the years, what we did was that I was involved in the World Health Organization rehabilitation guidance with return to work and daily activities. And there are some red flags that you have to rule out with COVID. So you have to rule out other causes of tachycardia. I won't go into too much detail, it's probably been mentioned, but you need to rule out things like myocarditis. You need to rule out arrhythmias. You need to rule out oxygen desaturation. And you need to, as Leslie has said, be very careful if somebody has post-exertional symptom exacerbation. So bearing all those things in mind when people are gradually returning to exertion, including work. As an occupational physician, I was asked to lead on the 2 documents that I've put here, and please feel free to use these links. We did a big document, a position paper, a couple of years ago called Return to Work, What Works, in relation to long COVID. And a very recent one, which is actually designed for managers, but is also for patients or people or healthcare staff to look at, because it talks in real detail about how to get somebody back to work. First and foremost, and I can't emphasize this enough, is treat the tachycardias and the orthostatic hypotension and the autonomic dysfunction. Because if you do that, people return to normal function much, much more quickly. And for example, I'll give my own example here. It isn't to do with COVID, it happened before COVID. I had various symptoms, not all of which I realized were due to my low blood pressure. And one of those was that if I was walking, I would, on the flat, within a few yards, I would run out of steam as if I'd run out of petrol. And a relative described it like the runner's wall, only it was happening after a few yards. And I didn't realize this was due to my low blood pressure, but once I went on fludrocortisone, my walking distance is so much better. It was almost miraculous. It took a few weeks, but I had no idea that my blood pressure must have been dropping to my boots just after being upright for a little bit of time. So there may be symptoms like that people don't even realize, so check their pulse and blood pressure. So I don't have time to go into the detail of how to return to work, but it is about early recognition and early treatment, and then very, very gradual getting back into the workplace. And just one final little slide here, along with the, you won't be able to read all this, but it's just to show you the picture in the link. It's an adjunct to the leaflet for managers, but it's a Mythbusters about long COVID and work and what you can do. So I hope those might be helpful links. Sorry to maybe run on a bit.
Okay, well, thank you very much. That was excellent.